Welcome everyone to the second and last day of the global meeting of the Working Group on Public-Private Mix for TB Prevention and Care. Thank you so much for joining us here today. And we see that the attendees are steadily increasing. We appreciate your support and continued collaboration. The first day was really focused on PPM progress, challenges, especially with a lot of presentations from countries. Today we're going to do a deep dive into the COVID pandemic and the private sector and the impact that it's had and how we need to build back stronger. And to lead the first session today, or session 3, is Dr. Madhu Pai, chair of the PPM Working Group, as well as director of McGill TB Center. Madhu, it's great to have you here. Over to you now for this very exciting session.
Thank you, Monica. Let me know if the slides are visible now.
Yes, yeah, they're visible.
Good. All right. So welcome back, everyone. And it's my pleasure to set the scene, introduce NIM, and then we have a very nice recorded panel with several private providers, followed by a live Q&A. So the big question that all of us are asking is, we know for a fact that COVID pandemic has badly impacted TB services. That much we know. We know case notifications have dropped everywhere. We know they've dropped in private and public sectors. The question is, what is this pandemic doing to the private healthcare market overall, regardless of TB? And then what are the implications for the TB PPM that we all care about, right? How badly are we off target in terms of TB PPM progress? And what do we need to do to bring it back? And how does someone like NIM or other modelers account for the disruptions that are happening to the private health sector so that we can then use that to refine the models that we may have? So here are several trends that I think we should all be watching out for. Each of you, us, in whatever shape or form we can collect these data, it'll be very, very helpful for us as a community. They don't have to be fancy research studies, but so long as there's some data from multiple parts of the world, it'll all help us piece together what is really happening on the ground. So I would argue that these are the most important trends to watch out for, and NIM will complement that and tell us if there's anything more we need to be collecting. First is there a shrinkage of the overall private health sector? Are there fewer facilities that are open? Are there fewer clinics? Are hospitals closed? Have hospitals collapsed or consolidated? And are fewer patients across the board seeking healthcare now because of all the concerns and anxiety of getting COVID, or they're just anxious to leave home for whatever reason? That's one. And there's some evidence, and I'll show you in a second, that that is indeed happening. Just like restaurants and small businesses, many of them are closed now, and we don't know how many of them will come back or not. Secondly, are patients now paying more for private healthcare? Again, there is data that this is happening, but we should collect that more diligently. There's also data that insurance premiums are going up. And these are really bad for us in TB, because if private TB care costs more, then patients will self-select themselves out of it and then go somewhere else. And we need to worry where they might be ending up with. Is there a change in provider mix? For example, are the more organized providers more likely to stay alive, as opposed to the one single clinic run by an elderly practitioner who's more likely to shut shop and never come back again? Is there consolidation? Are groups trying to merge together to survive this economic crisis? We know for sure patients are deferring care seeking, but is that still happening even when lockdowns are lifted? Are they still anxious about not going out with cough and fever? That is worrisome. We know for sure it happened during lockdown, but is it still happening several months later? We need to know. In what way are patients changing their care-seeking behavior? For example, if they're anxious to go to a public sector now because they fear they might get COVID, are they more likely to go to pharmacies or local practitioners and avoid seeking formal care? shift to remote care, you will hear from our private provider panel, this was a resounding yes from all of them, that this is indeed happening. They had no choice but to move to remote or telehealth services. Increased use of home-based care, and I'll show you some examples of that. Uh, Increased use of public services for TB. I'm not sure that this is happening because the public sector is still dealing with a lot of COVID, and there's a lot of anxiety among TB patients that even if they don't have TB, they might end up getting COVID if they went to crowded public sectors. So I'm not sure about that. I would like data. Is there any drop in TB care quality? So I'll show you in a second that there is some data that laboratories are testing fewer and fewer TB patients, even in the private laboratories. So if that is the case, then microbiological confirmation of TB might drop even further. And now, if I am doing telemedicine and I think you may have TB, I can easily send you a prescription through digitally. But how do I get your sputum test done? How do I connect you with the nearest laboratory? So I can see that lab testing might suffer through remote consultation, while prescriptions and drugs can still be delivered. And lastly, in what way is the regulatory landscape changing? We know for a fact, for example, Mumbai had to do all sorts of things to expand healthcare provision because of the massive need for COVID beds. So they had to take over some private hospitals. They had to purchase from some services from private hospitals. Price caps are happening everywhere in the world, of various degrees of price caps. Now, what does that mean for TB care is something we need to think about. So here is data from 25 private provider interviews done by our team, which is still ongoing, by Dr. Vaibhav, who's an anthropologist. And he found evidence, this is in India, and he found some evidence of shrinkage of private care. He's finding so far that elderly practitioners are more likely to completely stop practicing. And that might be a big loss because elderly practitioners are often experienced practitioners. Secondly, we found that there's increased pressure on private sector because public sector is still overwhelmed. When public sector is so busy, people have no choice but to come to private health sector. Very interesting adaptations of the network between pharmacies, private doctors, and compounders or clinic staff, where they are the ones now trying to connect everybody through WhatsApp and make sure something is still getting done. Lower testing volumes across all diseases in private laboratories. Just fewer people are showing up in private labs, and private labs had to fire employees or technicians because they can't allow have the economic losses mounting. Some providers have said that they've stopped diagnosing new patients. They're simply not either coming or they're not able to reach the clinic. And everybody agrees that telemedicine and home care models are the way to go because that's what people seem to want in this situation. Here is a graphic from today's newspaper in India showing how Indian private hospitals are coming up with home care packages for those who think they have COVID and we need to stay at home. They will even come home. They'll get a portable X-ray done for you at home. They'll bring you medicines at home. They'll come and collect blood samples. They can even do a high resolution chest CT, for Christ's sakes. Right? So the sector is capable of great service delivery innovation, but look at the price tag here. This is more than $1,000 for a US dollars for a home care for COVID. Who the hell can afford this? Which means this kind of models might well work, but only for the elite, not for the average TB patient that we're talking about. So for our average TB patient who's nowhere close to this level of economic costs, what is the option? Where will they get home care for TB and who is delivering it? And what is the regulatory framework for this kind of price gouging, right? Who is to prevent somebody from charging thousands of dollars for this kind of care? Right now, it's like free for all. Without proper regulation, this can go bad pretty quickly. And lastly, I have been writing along with several others that it's really time that we look at all the innovations that COVID is throwing up, whether it's technology or whether it's system, and find a way to repurpose it for tuberculosis. And I put the link for this article in the chat box. So here is a couple of examples. WHO is cataloging, Dave Clark and that team, interesting, innovative PPM models across the world on how private sector is being used to get additional surge capacity for dealing with COVID. So we need to track the same thing for TB. Are there innovative models that have cropped up in this crisis that we can learn from and adapt for TB? Secondly, we published a study of 15 countries with large private sector on what a PCR test costs for COVID. And just like we found for GeneXpert, the cost can be zero because government has effectively paid for it, or the cost can be $200 for a PCR COVID test out in the private market. Exactly what we found for GeneXpert in the past in the private health sector. If you don't do anything, you just allow the private sector to charge what they want, it'll end up becoming a $200 COVID PCR test and a $150 GeneXpert TB test. But with intervention, with price capping or innovative models like IPACT, one can pull this lower. But it also tells us that regulation and intervention by the government is actually quite critical to to make sense of all of this. Otherwise, we can have some really crazy things happen in the private sector that we need to worry about for TB as well. So I'll now stop sharing and invite Nim to load his slides. So Nim is a TB expert, a professor at Imperial, and a TB modeler. He's already modeled the private health sector and PPM in the past, but he's now trying to see what we can learn from the COVID pandemic and probably refine the model. Over to you, Nim.
Great, thanks very much, Madhu. Am I audible? Great, fantastic. So thanks very much to the organizers for the opportunity to join the meeting, but also for the opportunity to take part in some of this early modeling analysis. So I just wanted to share with folks some of the thinking around the mathematical modeling of the importance of private sector recovery to TB incidence and mortality. So just as a reminder, folks might be aware of this modeling study that that we conducted in collaboration with the Stop TB Partnership. And this was really early in the COVID response. I think this might have been around May or June. But in that case, we took a very high-level view of the TB epidemic in 3 countries, as you can see here, and basically asked the question, what would disruptions to TB services, what would be the implications for incidence and mortality over the next 5 years? And so for folks who are interested, this work was eventually published fairly recently. But we were finding from that work that, for example, if we had a 3-month suspension in TB services followed by a long period to recover to pre-lockdown levels, we could see an increase at a global level of TB incidence by around 11% over the next 5 years. And so I also want to point folks to some great work that was done by Philippe Glaziou at WHO that was published in medRxiv, and also some very nice work done by Finn McQuaid and colleagues at the London School that was published in ERJ. So along similar sorts of lines. But one of the limitations of this work was, of course, as I mentioned at the time, we were mostly interested in a reasonably high-level view of what these disruptions might do. And so all of these modeling analyses basically assumed a uniform shock across the public and the private sector, and uniform recovery as well. And of course, because we didn't have any data at the time, this was necessarily a prospective analysis that really depended on our assumptions for what might actually transpire. So of course, now we have information. So this is drawn from the most recent GTB report, which shows how notifications have changed in a select few countries. So I'll come back to this in a moment. But the questions that we want to address in the current analysis is, if we look back at the mathematical modeling that was done earlier in terms of incidence and mortality, what can we say about potential disruptions that are affecting the private sector, perhaps disproportionately and more heavily than they might affect the public sector? So I should mention, whenever I say private here, and using that as a shorthand for non-NTP, and so these are providers whose main focal service isn't necessarily TB, and recognizing the diversity of providers that this might contain. So the question that we've basically been looking at for this initial analysis is, what are the potential implications, again, for incidence and mortality over the next 5 years if TB services in the private sector only partially recover to pre-lockdown levels, and so Madhu spoke just now about the potential for, I think he called it shrinkage of the private provider base. And so here we're looking at this kind of mechanism happening. So perhaps only a fraction of private providers end up participating in TB services again, or even perhaps the cost of care, out-of-pocket costs, is so high that they remain inaccessible to an increased proportion of the patient population. So this is really what I want to talk about today. But basically, this is initial work. In follow-up work, which I'll mention at the end, we'd like to basically make use of the available and emerging data to analyze what the ongoing trends in notifications actually imply for these future projections. So once again, these are the figures that were presented in the recent GTB report. I should mention, folks might also notice that South Africa is missing from the bottom corner here, but I'm only listing these 3 countries because for the purpose of illustration, I just like to show these 3 as priority PPM countries. So for this analysis, I'm just going to assume this is, again, at a fairly high level, that whatever reductions that we see in notifications, that they reflect reductions in TB diagnosis and treatment initiation. So we know that there's some element of reporting delays as well here, but the analysis can always be updated and refined as those data are also updated and refined. And I'm also going to assume that whatever reductions we see here are affecting the public and private sectors equally. And so when, for example, we see a 40% drop in India, that this is something that applies to both public and private sectors. And we also know that the private sector only has some private providers notifying TB. And so these figures that we see here are only coming from those private providers that are actually engaged in the system of reporting. So I'm also going to assume here that whatever disruptions we see in diagnosis through notifications, we can extrapolate that also to non-reporting private providers as well. So I just want you to imagine a scenario. So this is a scenario that we've basically modeled in terms of the future recovery of the healthcare system. So firstly, that the public sector or the NTP services recover to pre-lockdown levels within 3 months, right? Perhaps as a sort of extrapolation of this trend for India that you see here. But that the private sector only recovers to a fraction of its previous capacity. So I'm going to look at the best case scenario where it comes back to full capacity, a worst case scenario at 75%, and a worst case scenario at around 50%. Now, I have to say, I think the 50% scenario is probably, a bit extreme. I personally don't think that, we'd be seeing disruptions of that magnitude, but I'm just putting it there to as an illustrative example to give some sense of the potential burden that could accumulate. So, just to give you results in the example of Indonesia, this left-hand plot is showing projected incidence, and the right-hand plot is showing projected mortality. And the blue line is basically the projected trend in the absence of any disruption. And if we had a scenario where there were COVID lockdowns, and then we have full recovery within 3 months of both public and private sectors, within 3 months, then these are the projections. You can see there's a small dip in terms of incidence early on, and this is because of the transmission reductions in TB that we might expect to have happened as a result of the restrictions. But in the long term, there's a net increase in TB burden. And so we can also look at this in the case of recovery to 75%. So this is 25% shrinkage, if you like, in the private provider base. And similarly, if we recover only to half the previous capacity in the private sector. And so we can, this being a model, we can also put numbers to the increase in the cumulative TB burden. And so if we're looking at incidence, for example, the best case scenario, we're looking at perhaps a 7.5% increase in cumulative incidence over the next 5 years. And in the worst case scenario, and again, this to me is a fairly extreme case, we'd be looking at around a 40% increase in cumulative TB incidence over the next 5 years. And roughly similar numbers if we're looking at cumulative TB deaths as well. So we can redo this analysis for India, for example. The projected impacts are a little bit less. Around 5% increase in cumulative TB cases and deaths between now and 2025 in the best case scenario, increasing to around 20 to 25% increases in this extreme case of 50%. And finally, I showed the Philippines earlier. And so these are projections for the Philippines. And again, using only the information from the WHO GTB report. And you can see here the impacts are rather less in the case of the Philippines. And this is partly because of the rather unique epidemiology there compared to the other two countries. But we can come back to this about the differences between these countries if this might be of interest in discussion. But one of the main points coming across here is basically that the actual impact of private sector disruption could be quite context specific. It could vary quite widely from country to country, depending on the local conditions. So just to conclude, the recovery of the private sector could have really critical importance for the future burden of TB. And as I mentioned, the actual severity of this impact could be very context dependent, depending on the local conditions in different countries. And so, for example, in perhaps the most extreme example that we see, we could see up to about a 40% increase in cumulative TB incidence over the next 5 years. Now, I should mention this is all illustrative, and it is basically just looking at certain scenarios for how the future might play out. But of course, we do have data for these notifications. And so in the next steps in this analysis, we plan to do a country-wise analysis of what's actually happening in terms of notifications from the private sector. This is using monthly data stratified by public or NTP and non-NTP providers, but with a focus on the 9 priority countries for PPM. And that concludes my talk, and thank you very much.
Thank you, Nim. Really helpful. So one caveat would be that if we just looked at the trends in private notifications, we still cannot tease out why that is happening, right? Because some of it could be the private sector has priced itself out and it's only serving the elite now, not the average person, or the private sector has shrunk, which also I think cannot be teased out by those notification numbers. So really important to understand in what way or shape the market is changing. Can I ask you a quick question? And I have one question from William that I'd like you to answer before we move on to the panel. There is plenty of evidence now. For example, India's economy has shrunk by about a quarter, right? The GDP in the first quarter, and the predictions are even dire. So if more and more people are going to be pushed into poverty, right? Phenomenon one. Second phenomenon is private healthcare overall becomes more expensive. What might the combined effect of these two forces do to us in TB? People are poorer, they have less cash, and they have to pay money now to seek private healthcare. What really happens to them, and how will that show up in your model?
This is just a off the top of my head answer, and I'd love to see when any of this actually transpires. So before we were seeing, at least in India, that very interestingly, even though patients were incurring out-of-pocket expenditure to see private providers, they were the dominant primary care, source of primary care. If that source of primary care becomes increasingly unaffordable for both of the reasons you mentioned, we may well see an overwhelming demand for public care or free at the point of care. And that raises real concerns about the capacity to absorb them. But at the moment we're not looking at specifically at capacity questions, but I think this would only add to the delays that we're already seeing.
Good point. This may well be an important shock to the system that brings patients back into the public system because they have very little choices outside. Guys made a comment that in some settings like Shops Plus in Nigeria or Green Star in Pakistan, private sector notifications have more than recovered, which goes to your point that might be very context specific. Secondly, William wants to know, what are your hypotheses about drivers of recovery to 50 or 75%? And is there any way of testing them?
Yes. So it was really interesting. I think it was in the TB PPM, one of the sessions there, where we had colleagues from, if I remember correctly, Nigeria, talking about private care there. And they were saying that a lot of private providers were very unwilling to treat respiratory illness, partly because, of sanctions against them for doing so. So there has been a lot of disincentive, it seems, for treating respiratory illness. And I imagine, as I'm just trying to imagine myself personally as a private provider, perhaps, this is one part of my service provision that I'm just not interested in doing anymore. And I would tend to refer people to the public sector again. But also, it's very interesting to hear the comments that you mentioned earlier, Madhu, about, particularly elderly providers in India shutting off shop and not opening again. We don't know how many of these folks might reopen over the next 6, 9, 12 months. And we don't know whether this is going to be limited to elderly providers or, even a wider part of the sector. So it's a shock. And basically, for all of these reasons, we may well see recovery to less than 100%.
Thank you,
I hope
Nim.
that answers this William's question.
There's a couple more questions on the Q&A box. Could you answer them or type your answers to them in the box, Nim? We have our private providers waiting for us, so we'll move ahead with the panel. And then when the panel Q&A comes, Nim, you will still be around, so we can have a broader discussion as well. So Monica, can you now tee up our panel, and then we'll do the Q&A.
Sounds good, Madhu. So I'll do that. But just to remind everyone that the Q&A function is where we will be collecting questions. So grateful if you could use that to post your questions. Okay.
Hi, everyone. Welcome to this panel discussion. My name is Madhu Pai. I'm the chair of the PPM working group. As you all know, in many high-burden countries, private sector is a huge source of TB care and medical care. But then during this COVID crisis, the private sector has had a very, very challenging time. In many countries, they've had to close services for a long time. In many settings, private sector care is becoming harder to access or more difficult to access or expensive to access, and TB notifications have fallen in public and private sector in many countries. So the big question for us is, in what way, shape or form is the private sector changing to survive during this COVID crisis? And what impact might that have on tuberculosis services in these countries? PM to work well, we need a good functioning private health sector, and we need them to take care of TB and at affordable costs, and we need them to also work with the government to make this all happen. But right now we are worried, very worried, that this might all be falling apart on the ground. So it's good to learn directly from people, providers on the ground in high burden countries, and ask them how they are surviving during this crisis, in what way has their private practice changed. So we have a few really good speakers with us today. I'll have them introduce themselves to you in a second, and then we will go and ask them a few key questions and ask them how they're managing. Dr. Fini, would you like to introduce yourself?
Thank you for inviting me to the prestigious meeting. I'm Fini from Indonesia, Padang City, West Sumatra. I'm a pediatrician. and work in Faculty of Medicine, Universitas Andalas, and M. Jamil Hospital too, and work in with the National TB program too. Thank you.
Hello everyone. I'm Dr. Vikas Oswal, a private chest physician, pulmonologist practicing in Mumbai, and also collaborated along with the corporation and the NTEP. Like I'm a national trainer taking training sessions everywhere all over India for the latest PMDT guidelines for terrorist tuberculosis, and play a major role in practicing a model of NGO-based private-public partnership everywhere. So we have got a good collaboration of this NGO, corporation, and a private sector, all three coming together. And we have come up with a model where we practice in this model, and we are trying to replicate this model everywhere, all over India very soon.
Okay. So my name is Dr. Naseem Akhtar, and I'm basically a clinician, a medical specialist, as well as an expert in infectious diseases. I was previously working with COVID isolation unit, and I, managed the first wave of COVID-19. And recently, I have joined National TB program as a national program manager. And currently, I'm working with the program. I'm really grateful for inviting myself for this important discussion. Thank you.
Hello, everyone. I'm Dr. Lidanek. I'm the medical director of Ava Medical Practice. We run a private facility in Lagos, Nigeria, and then a bunch of clinics across Nigeria itself. But the main practice is in the hospital that's in Lagos.
All right, so I have a series of questions, and if you can all keep your answers very short, then we can do as many questions as possible to get a complete picture. So please keep your responses very brief, with the understanding that we have many questions to cover. So the first big question I have for all of you is, we know private sector notifications have dropped, but has the private sector, health sector in your country shrunk in any way? In other words, are the number of private clinics or providers or hospitals or beds reduced in some way because of this COVID crisis, lockdowns, economic losses, and so on and so forth? What is your quick assessment? I know you may not have data, but what is your gut sense of how it's going on? Dr. Finney, what do you think has happened in Indonesia?
Yeah. Okay, thank you, Dr. Madhu. You know that in my country, we have many private sector, and especially in my city, Padang City, we have about 20 private hospital and more than 50 private clinic. That when the COVID-19 come, the first 2 months, the private sector decrease of the patient visit, and special for me and some my colleagues not come to the private clinic for 2 months. We only come to the main hospital for only 2 and 3 hours for visit the patient, and the private hospital very almost collapse maybe, but in the 3rd month the private hospital start to resetting back the services, and then step by step they receive the patient, and patient more convenient to come because the private sector have the pathway to receive the patient, infectious or not infectious, like this. That's all.
So you're saying it temporarily had to close, but now it's coming back?
Yeah.
But is it back at full strength the way it was before COVID, or do you still think it's less capacity than before?
Not yet. For the 3 months, the last 3 months, we have the increase of the patient. The private sector increase the patient and receive the COVID patient too. And many hospitals have the make a new ward with to COVID-19 too. So this is the adaptation of the private sector, and they hope the government can pay back the infestation of this what I think.
So you're saying even though private sector has come back, it's kind of busy taking care of COVID right now. The private sector is taking care of COVID patients.
I think not fully come back, but not normal. But I think it still have the saving to pay the human resource, health worker, and other.
Thank you. Because we know India had a very brutal lockdown for several months, weeks. What is the situation with the private health sector? Forget TB in general. How do you think private sector has changed?
Definitely, there was a lot of change over here, if you ask me. Each and every availability of the physicians was a major challenge. Hospital beds, there were no hospital beds to admit anywhere. Majority of the corporations, they have asked all the majority of the hospitals to convert them to COVID hospitals. Many of them were forced to get converted to COVID hospitals over here, because of which admission process had become very cumbersome over here. Like there was a big challenge for all the patients, non-COVID patients, to go and get admitted. This was definitely there. Second thing, availability of physicians was a biggest challenge. All the clinics, even the government clinics, the government OPDs were also shut down over here completely. Each and every OPDs were converted to COVID OPDs, that is fever clinics, COVID symptoms, COVID suspects, and all those clinics were running over here everywhere in all the hospitals. So managing non-COVID patient, we had to go somewhere, and we had, we actually required to create some different path for those non-COVID patients, especially for tuberculosis. When we see India is the hub of tuberculosis, we really faced challenges to dispensing of drugs, to diagnose new cases, to give injectables for the patients who are already on second-line injectable, to diagnose drug-resistant tuberculosis, or to segregate them, or even the logistic, rather, in that manner, the logistics of the drugs from the central drug stores to the peripheral health centers, or even giving it to the pursuit of the patients. So all these challenges, we had to come up with some different plan of action, and we initial 2 months it was tough. It was a tough situation over here, but after 2 months we had to come up with some other plans.
Thank you, Vikas. So you said there was a lot of disruption to private healthcare during the lockdown and after. But where do you think it's in India right now? On the one hand, COVID has not gone away. Do you think there is still a residual impact on the private health sector even now?
Now I would say no, because each and every person over here is just fed up of this lockdown, is fed up of being scared. Now they probably have just you can say got used to live with COVID, so they're like ready to face the challenge. Let COVID come, we'll see now what to be done, rather than sitting in home this way, where you're going to lose a lot on economy, you're losing a lot on other relationships, you're losing a lot on other partnerships, the dealing, the economy is going down. So each and every person have just made up their mind. So let us face this. Whatever comes up, we will face it. So and I think now each and every person have just opened up their minds and courage. They have become more courageous, and they are live along with COVID now. This way, where you're going to lose a lot on economy, you're losing a lot on other relationships, you're losing a lot on other partnerships, the dealing, the economy is going down. So each and every person have just made up their mind. So let us face this. Whatever comes up, we will face it. So and I think now each and every person have just opened up their minds and courage. They have become more courageous, and they are live along with COVID now.
Dr. Naseem, what is the private health sector situation in Pakistan? You said COVID continues to increase now. Is the private health sector functioning as it was before the pandemic, or is it really shrunk or contracted?
Yeah, thank you very much. I would say that, as you know, that COVID started a bit late in Pakistan. We received the first case of COVID-19 in the end of February 2020. And with that, in the next few months, the number of cases increased drastically, and all of the hospitals were full of the patients, and the situation was even worse with the private setup. And there were many challenges which were faced by the public as well as by the government and by the people. And you know that if we compare the TB notification from the previous years, definitely it dropped down drastically as compared to, you can see, 2017, 18 or 19. And we have seen this change in both in public as well as in the private setup. Although there was a little difference between them, but definitely the case notification dropped from both sides. And definitely there were so many challenges, and I would agree with Dr. Vikas that we had almost the similar problems which India faced or maybe some other country faced because there was a lockdown. Although the Pakistan adopted the policy of a smart lockdown, but definitely there were areas where there were strict restrictions of movements, and people could not move across. The hospitals were closed. Many private hospitals were closed. And there was also the fear and stigma of COVID-19, and the people were afraid of contracting the disease if they go out. So definitely there was a big challenge, and that was the main reason that the number of case notification decreased. And the private healthcare facilities, even the laboratories were also closed because of the fear of COVID-19. And again, you can see that initially there were also challenges of having personal protective equipment and certain different hygiene items as well. Screening activities were also brought to complete halt as there were some problems with mobility of mobile X-ray vans. They were no longer permitted within the facilities, or outside the hospitals in the community setting. So there was this restriction as well. Then there was problem of referral as well, because so many private clinics were shut down, and we were not getting referrals from the TB diagnostic centers and from the private hospitals as well. And similarly, there was also a decrease in the walk-in patients who were presenting to the CHS centers. More so, we also face the challenge that many of the healthcare workers, they also contracted the disease during this pandemic. And that too, number of the staff working in the hospital was also less. But as the pandemic continued with the passage of time, the number of cases dropped down in Pakistan, and we had a period of 1 to 2 months in which the number of cases were very low. But again, we have noticed that in the last 1.5 months, the number of cases has gone up. Maybe we are facing the second wave of COVID. But I must say that during the whole scenario, still the private as well as the public sector hospitals, they continue to work for TB. They were not completely closed, and we continue to have close collaboration with the key stakeholders. And I must mention that a few of our private partners were, still engaged during the whole time. And I would appreciate the activities, carried out by the Indus as well as the Mercy Corps. And we kept on working in close coordination with each other. We continue to work in certain things like for the program continuity, and we started adopting the guidelines for the COVID-19, and gradually the stigma and fear, has come down. But still, again, we are facing the challenge that probably in the coming few months we might have certain more issues, like the cases are going up. But still, I think there is a little bit sensitivity among the people. Now they are not that much, stigmatized as they were previously, and now the hospitals are opened up, and the private sector has started working again. We continue to work on program continuity, and we adopted certain guidelines. We worked on guidelines. We ensured the delivery of medicines at the GP clinics as well as at the doorstep of the TB patients. Almost 90% of the TB patients, they continue to receive ATT drugs during the whole pandemic. And similarly, the patient's follow-up and contact screening was also maintained. And I think public-private partnership was, it was good, ensured, and it was supported by the activities at both ends. So there are challenges, but I think we try to continue the program, and we try to adopt to the situation. Yeah.
Thank you, Dr. Naseem. Thank you. So, Lillian, could you tell us a little bit about what the private health sector in your area is looking like? So, I'm sure you had a partial lockdown or a full lockdown in the early days of the pandemic. But what is happening to the private health sector now? Are the clinics still functioning? Are the patient footfalls continuing? Do you think there's any disruption to private health sector?
Yeah. So really, I think COVID has shown the resilience of the human nature and how people tend to adapt to things. Because, I mean, I'm sure we've seen it in memes all over the place. When COVID first started, the fear was like so, and then, you know, even the incidence was like so. But now the incidence is like this, and people's anxiety about COVID is, you know, is reducing because everybody just takes it as part of life. So that's exactly what the scenario in Nigeria, Lagos specifically, which is why I practice. And I think it's even worse or more heightened. Let me not use the word worse because worse implies that it's bad. It's even more heightened because in Africa, as I'm sure the Africa CDC, you know, has emphasized, we are not getting the kind of mortality rate from COVID that is happening in the West. So, I mean, because of that, it's after the lockdown, and I think all lockdowns actually across Nigeria have been eased. The markets which were shut at a point or functioning on alternate days, markets are open, banks are open, running full time. You know, everywhere is just functioning as before. So footfall has almost gone back to normal. I wouldn't say it's normal, what it used to be before. People are still wary, but it's not as bad as, you know, one would have thought it would be, or as bad as it was during the lockdown when no one was moving at all.
Thank you. So the next important question for all of you, and a very quick response, please. Do you think, based on your observations, that cost of private healthcare across diseases, across conditions, cost of private healthcare has gone up as a result of what has happened in the last several months? Vikas, what is your quick sense on this question, cost?
Yes, costs have gone up. The reason being is you don't find a staff working at the same salary like before. You are forced to pay double the salary to RMOs, double to the nursing staff, double to the root level workers. So obviously, when your expenses are more, you're going to recover this expenses somewhere from the patient's pocket also. You are forced to, rather. So yes, the costs have gone up. Secondly, for doing a procedure like a surgery or even a minor procedure, you require screening of the patient. You require to sanitize your OT, which is already sterilized, but still you have to take some extra precautions over here. Provide PPE kit for protection kits for each and every staff over here, because of which the prices are going to get raised. Plus, so there are certain challenges which, as a healthcare workers or as an administrator, rather, I would tell over here, I am facing these things because even I am a CEO of hospital and I'm a managing director of hospital also. Somewhere we are forced to raise and recover this from the bills over there. Don't want, but still we are forced to raise the bills over here.
Understood. Very, very honest, candid remark. Lillian, do you think private healthcare is becoming more expensive in Nigeria right now?
Yes, it is, and sadly so. Global disruption of supply chains has meant that cost of medication has gone up astronomically. The fact that, I mean, like my colleague has said, Dr. Vika has said, the fact that we have to wear PPEs, patients need to be screened before they come into theater, the constant sanitization of the hospital environment, all of that cost adds up. And somebody needs to pay if the healthcare systems remain profitable and not collapse in its entirety. Sadly, that cost has to go to the patient. So yes, the cost of healthcare has.
Thank you. Finny, does that match your impression in Indonesia?
Similar with India and Nigeria, maybe more of our health workers have the panic situation. So the PPA, we should spend more money for PPA. So private practice and private hospital should have the budget, more biggest budget bigger budget for spend the money for the equipment.
Thank you. Thank you. Dr. Naseem, what do you think is happening in Pakistan with cost of care in private sector?
I think it has definitely gone up, and most of the patients who prefer to go to the private sector, definitely they are paying a lot. And the reason being that we had to provide PPE to the hospital staff, to the nursing staff, each and everyone who is working there. And similarly, I would say that since these patients needed isolation and separate rooms, and similarly those patients who are admitted in high dependency units and in the ICUs specifically, I would say that the cost went up too much, and it was not possible for a common person to pay for that. And thanks God that the government hospital were also in action, and definitely in the government hospital somebody had to pay by the government, but obviously so many patients they had a benefit of being admitted there, because the length of the stay was also getting prolonged. Roughly average stay of the COVID patient was at least 2 weeks, and sometimes it went up to 4 weeks or 6 weeks because of the complications and all that. So I would say that definitely the participation of the private sector was good, because they shared the burden of the government to handle such patients. Obviously the government hospitals could not take so many patients because of so many cases. I must say that they contributed a lot, but at the same time somebody had to bear the cost. So definitely the cost of PPE, the cost of medicines, and there was a time when we used to procure certain medications for COVID-19, like interleukin-6 inhibitors or remdesivir or all that, and PPE. Obviously there were so many trials going on. We were also interested in getting plasma therapy and all that. So everything contributed a lot. So definitely the costs were very much higher in the private sector as compared to the public.
Thank you. So this is so clear that this is happening across countries, which brings us to a very critical question. So imagine you and I were a TB patient in India now. Earlier, we would have probably gone to the private sector in Pakistan, Indonesia, Nigeria, or India. But now I'm seeing as a patient that cost of care is shooting up in the private sector. I don't have that kind of money. Now, what am I to do? I have cough and fever for 2 weeks. Is my likelihood of changing my normal care seeking pattern very high now? In other words, how are patients adapting to all of what you've just said? So are they now more likely to go to public sector? Are they more likely to go to pharmacies or informal sector because they can't afford or they're scared of going to the private sector? So very briefly, give me your gut sense on how patients are changing their care seeking if they had respiratory symptoms. Finny, you want to go first?
We have the patient should have the choice for formal sector or the private sector. So the private sector should have the networking with the primary healthcare and other to make a better service for TB. So because many of formal sector, like my hospital, third level hospital, move on to the lung clinic and lung ward, move to the COVID isolation ward. So all of our TB-MDR patients move to the other hospital for TB-MDR. And some of the patients loss of follow-up because they cannot reach the place. So from now on, we should I think we should make a decentralization, more decentralization of the TB-DR, TB sensitive, and including the children. I have the pilot project with my magister student to use midwife to control the TPT, investigation, contact investigation to control the TPT after the doctor diagnosed, and maybe the decentralization can increase the adherence.
But, okay. Got it. Dr. Naseem, do you think patients in Pakistan have had to make some difficult changes or choices with their care seeking?
Yeah, I would say that as far as the TB care is concerned, so since we had many private partners with us who were obviously working with us, and similarly we also have the PMDT sites. Although it was difficult for the patients to reach to those sites, but I would say that these sites were not completely closed. Although the patients were having difficulty reaching there, but our setups were not closed. Although our staff was less in number, but still I would say that these sites continue to function. And our private partners, they were providing free of cost services, during the whole pandemic. But I think the main problem was the patient that they were unable to reach to the sites. So some of the activities were continued, and in the initial period of time, actually the patients were not aware that these sites are actually open. And probably they had some, misconception that everything is closed, but actually it was not. So I think with the passage of time, the patients started coming to the sites, and as I already said that there was uninterrupted supply of the medicines. So there is now less stigmatization. So people are coming; they know that the sites are open. The private partners, they continue to offer services, although in the limited capacity, but it was not completely halted.
But do you think, Dr. Naseem, are the patients coming back into the public sector for care now because private sector is difficult?
Yes, they are definitely coming. Especially, I am talking in the context of TB, because they know that the sites are open and they have started coming. And the number have gradually increased, and probably I think in the coming days the number will increase more.
Thank you.
Yeah.
Because what do you think is happening to patients and their choices?
If you ask me, over here, patients have found their own ways. Rather, we physicians also had to welcome these ideas and giving these extra services to our patients by starting up and coming up with teleconsultations. Because that was the easiest way to reach directly to the patient, and patient directly coming in contact with the physician. He never opted to shift from public sector to private sector. To be very frank, neither any public sector shifted to the private sector. So there was no exchanges of any of the patients in any of the sectors. That is what is our experience. Because I am practicing in both, I have hands in both public sector as well as private sector over here. So being a private chest physician, I used to get calls from patients. Sir, kindly do one video call a day right now. That's more than enough for me. So they accepted this teleconsultation very easily, because of which even we had we had made it officially to IMA, Indian Medical Association, and given an written approvals from the corporations and the authorities that we are starting this teleconsultations and making it officially, so that we don't come up or land up on any medical legal consequences later. So we had an official welcome letter, an official letter from IMA and the authorities at least in India.
So how widespread are teleconsultations in Mumbai right now?
Okay, in Mumbai right now, so if you ask me, amidst of the complete lockdown, 100% was teleconsultation. That is non-COVID patients. Even COVID suspects started with teleconsultations, landed up in the hospitals if required admission. If not required admission, majority of them were managed at home quarantine itself. Tuberculosis, each and every patient was managed on teleconsultations. So we had to just call our patients, the patients to take an appointment. Appointment was been booked. We called them on the respective given time. We also did a video consultation if required. If not, only audio consultation was been done. Immediately a prescription was being generated as per the requirements. Patient was being given an add-on services over here for home collection or for any blood collections if required, for home collection of sputum, gene expert or sputum sample collection from the nearest place, wherever is the nearest reach for the patient. This services was been added for our patients over here. And then the prescription was being generated, and we made use of the social medias say WhatsApp, which is very easily available in each and every smartphone right now. So we made a maximum utilization of this WhatsApp social media, and which gave us an idea to why not make it more refined way, So an official software was been made, at least in process was been been brought up officially, and the software also helped us further. Where we had a good appointment schedules, reminders to the patient, reminders to the physician, even a payment gate was being provided over there, reviews, feedbacks, everything. So,
thank you. So looks like this remote consultations is really taken off from what you're saying. Is it still happening even now, even after without lockdowns? Is it still continuing?
Oh, yes. We had an added benefit over here since the remote since the teleconsultation was officially been declared over here in Mumbai. So and when this message got widespread everywhere, we had an add-on benefits of getting consultations from intra-states also. So from different states like Delhi, Ahmedabad,
and you get paid for it. You get paid for it.
Yeah, you get paid for it.
Very good. Okay,
you
thank
won't
you.
believe I have patients even in Dubai right now, sitting in Dubai as well as.
You want international. Okay.
Yeah. So now teleconsultation since it's officially, so I'm just having no restriction over here. So we are getting consultations from everywhere.
This might be a silver lining that to come out of this pandemic. Lillian, can you tell us in Nigeria, are providers and hospitals and clinics making teleconsultations a possibility?
Yes, we started teleconsultation because of COVID. That was an attempt to help us triage and know who was coming in, what they had, and how we could best serve the patients and also protect staff. But that has gone on to expand to a number of things. Drop-off medication for patients that want medication, phone-in consultations, video consultations, either we're using Microsoft Teams or we're doing a WhatsApp video call where appropriate and depending on what the patient wants. But the challenge, and a number of apps have come up in Nigeria that do this, 3, 4, 5 apps, that are being downloaded. But the challenge is changing the healthcare seeking behavior of Nigerians. And again, because of how the pandemic has behaved in Nigeria and indeed across Africa, because COVID is not as much of a danger or a threat to life the way it is elsewhere in the world. People are happier to come into hospital. They're happier to do a physical consultation than to, to go and to have something done online. Well, I don't know, I'm not conversant with the doctor. The doctor can't do a full examination. I'm not sure if his assessment of my condition is thorough enough. So there's that measure of distrust. And to answer your first question, which is where we started off, if I may, is which was about what are the patients doing now? During the lockdown, many patients were going to pharmacies because the cost of care was, it was difficult getting to hospital. And even now, if the private sector is costing a lot, government hospitals, there's always this concern about, quality of care, distrust, what's going to happen if I go there. So people are happy to just go to a pharmacy and, complain and get their medication. That has been happening, yes.
Thank you. Dr. Naseem, very briefly, are teleconsultations happening in the private sector in Pakistan?
Yeah, I think the Pakistan also worked on medicine as well, and I think it was very successful, and we were able to manage so many mild cases of COVID on telemedicine, and in this way we were able to keep those patients at home. Otherwise, the hospitals are overburdened already, and this tele health definitely worked a lot, and we intensified these services during this pandemic, and call center was established and there was a UAN number, and it was used to log patients' complaints or their adverse events for active management of the patients. And I think many follow-ups were maintained and the counseling services were provided to the patients. It really worked good. So I think it was a real good experience, especially during this pandemic. And I would also like to mention one more thing, that we also started working on decentralization of our services. And I think in Pakistan, this is going to make a big difference to provide the TB services at the doorsteps. Another very good step which was taken by our partners, private partners working with us, was that we worked on the drive-through or walk-through screening of the patients, especially in Karachi and Islamabad, and that also helped us a lot. So the active case finding was continued, although it was less. But I think the mobile X-ray vans were used for screening of the COVID cases as well as TB cases during the pandemic, and I think it was really a good thing because we did not completely stop the things, and we continue to work in the limited, setting.
So we're almost out of time, and I want to ask one final thought from each of you. We know for sure TB notifications have dropped in all these countries, especially in private sector. We know TB testing has dropped. What is one suggestion you have from your experience to find all the people that we have missed in the private health sector? We have missed thousands of people in the last 8 to 10 months. What is, in your opinion, the quickest way to bring back those people that we missed with TB and get them started on treatment again? One suggestion that you think can really help us reduce the missing TB gap because of COVID. Vikas, we'll start with you.
Sir, I would say do not worry. The notification has gone down. This is a temporary drop. The cases are obviously going to be there in the field. They're not going to get cured on their own. The patient have to reach physician. Once they reach physician, they will be forced to diagnose the case. They will be forced to notify. So these notification figures are definitely going to go up very soon. The moment you want to start.
What is the best way to find them now? All the missed people. What is the best intervention?
The best intervention is to make your services available as early and as nearest to the patient as possible.
Got it. And teleconsultation is one way to do that.
Perfect.
Okay. Got it. Next. Finny, what do you think is a intervention that can help us find the missing people right now?
Yeah, I think the private sector should have the close relationship and close networking with the primary healthcare around there, and primary healthcare will support the private sector to send referral to patient to the private sector, and private sector should have a dual service, TB and COVID-19 directly in the one visit, and so good opportunity for the increase. Yeah.
Thank you. Lillian, what is your one advice or suggestion?
It's two things. One, the patients in the lockdown were going to pharmacies. We need to empower the pharmacies, patent medicine vendors to do more screening because they are closer to the people, and that's where the people will by default go based on their health-seeking behavior. Two, emphasize telemedicine, but not with the phone-in consultations, not video. The cost of data remains high in Nigeria, makes video consultation with things like Zoom or Teams or WhatsApp a bit of a challenge. But if you can just call in and say, I've been coughing, I have a fever, I don't feel well, and get advice, then that would significantly help.
Dr. Naseem?
Yeah, I would say that the decentralization of services is the one most important thing, providing the screening as well as the treatment facilities at the doorstep of the patients, number one. And we have already started working on that. We have started, decentralization of the program in Pakistan. And secondly, we have a very good network of lady health workers. They are engaged again with active case finding and TB notification. The second thing is the mandatory case notification. We have started working on that, and it has been implemented in 2 provinces, and it's being implemented in rest of the provinces as well. And we're engaging lady health workers. Just we are trying to ensure that the services should be decentralized. And we have also, ensured that we continue working during this pandemic with TB patients, and we have not stopped our meetings virtually. Like all the intra-district and inter-district meetings are still going on, and we are in close collaboration with our partners, with our, colleagues from Pakistan most of the time, and we have not stopped our activities, and we hope that we will cope up with this situation. And as we have to live with the COVID, we have to, continue working with the TB patients. We cannot just sit and wait. So we are doing it.
Thank you. This was an incredibly useful and insightful panel. So if I were to just summarize what I've learned from all of you in 1 minute, that would be that private sector was badly hit during the peak of the pandemic in all countries, but the private sector is slowly but steadily bouncing back. It may not be back to normal levels, but it's trying to get there. Private sector care has definitely become more expensive. Patients are changing their care seeking pattern on the basis of all of this, and they are wanting care closer to homes, whether that is through teleconsultations or whether that is through pharmacies locally or primary care providers. They are reluctant to go far away or to difficult to access places. And TB notifications and testing have gone down, but one way to recover from all this mess and bring back all the missing people is to go and find them close to home, because even now they are quite anxious about going and seeking care. And so all the adaptations that you all mentioned would be very, very useful, I think. Remote consultations, sending and collecting samples from home, sending medicines to home, using local pharmacies and getting them to refer more, or using informal providers or community health workers, finding any and all methods to reach the patient rather than wait for the patient to come and get into the private health sector is the way to go. And of course, we have to find a way to make the cost issue more affordable for patients, because otherwise that would still be a big barrier. And I think this is where I think national TV programs can play a big role. If they can compensate the private sector and pay for these additional costs, like PPE, maybe the cost to TB patients can be ameliorated or reduced somewhat. So thank you so much for all the wonderful work you're doing and for the time you've taken out to participate in our PPM working group meeting. Over. Great.
So over to you, Madhu.
Yes. Thanks, everyone. Great to see all of you here. I hope you agree that was a very, very fascinating panel, and the panelists, some of them are with us right now. Naseem, Vikas, and Finny. I'm not sure if anyone else is on the panel, but we can ask them questions. So I'll start with one comment I think that has been made, that the panel might have reflected more an urban perspective rather than remote rural areas. And I think we need to acknowledge that. So it's quite possible that telemedicine might be less effective in rural areas. I think we probably need to bring rural practitioners into this forum to kind of learn more about what they have to say. Blessy, can you ask your question and put your camera on if you wish?
Thank you, Madhu, for the time, and thank you, panelists, for that really, really great panel discussion. Really enjoyed it. Just a couple of things. One was I wanted to ask about the bidirectional screening that Ministry of Health, Government of India had announced. What we are hearing from the ground is that it's really not being done. So I wanted to know if I think it was Dr. Vikas from India, right? If there's anyone else, you could kindly comment on that, how it's going. Is it good? Will TB suffer because of that? Just would like to get your input on that. And the second point I wanted to make was about stigma and fear. The civil society did a COVID TB interruption of TB services survey, global survey, and came out with the report that was launched recently called Community Perspectives. And in that, we really saw that stigma had a huge effect. And I'm wondering, in the private sector, do you see that? And how are you addressing that? What are you doing to address that? Thank you very much.
Who wants to respond to this?
Yeah. Regarding this first one, the Union Health Ministry has directed the authorities to conduct this bidirectional COVID-19 TB screening. Scientific studies are already showing, as per them, that history of active as well as a latent TB, an important risk factor of SARS-CoV-2 infection. Now what they are telling is like, this tuberculosis, they have also something to do with the comorbidities, lot of comorbidities over there, that they tend to have comorbidities or the living condition, the malnutrition, diabetes, smoking habits, more HIV, and that's the reason of their increasing vulnerability, more of increase of vulnerable population. And maybe that was one of their idea for making it as a bidirectional. So let all TB be tested for COVID also, and let all COVIDs be also be screened for this one. So yes, it has been followed right now in all the centers over here. If you ask me, at least in our, at least in Mumbai, they have covered majority of the healthcare services, the PHC over here. So now the DRTP sites were informed each and every patients to be screened for COVID. This was been informed, and till now they are been doing this. So don't know how it's really going to help or not, because if you see as a personal experience, what I found was in my cohort, like in my TB cohort, I found very less COVID, to be very frank. Like if you ask me, there was hardly 0.4% of my cohort getting COVID. But still, now this is something what they thought that probably this TB would be something big along with comorbid conditions, and so let us screen all of them for COVID. Maybe that was their idea.
So I think Vikas and Blessy are raising a really important question for all of us. If somebody has 2 weeks of cough, and you first insist that they get a COVID test before you test for TB, and if COVID test is a massive bottleneck in many countries, then are we effectively delaying TB diagnosis by first insisting that a COVID test be done? To me, that is not smart way of designing it, because at any cost, if I can do a simple TB test and if it's available, I should not wait for any COVID test to come along. I should just do the TB test. I'm fine with doing both, but what I don't think we want as a TB community is COVID test to become the bottleneck for TB testing. That to me is just completely nonsensical, because no country has sufficient amount of COVID tests right now. Not even the highest income countries are able to offer sufficient COVID testing. So we cannot make a more scarce test the first test in the algorithm. Whatever is easily available, and if it's 2 weeks of cough, we should absolutely chase after TB and not demand a negative COVID test before we start testing for TB. I'm just putting it out there because this has some very serious consequences for further delaying TB diagnosis. And I think all of us have a bad feeling that already people are delaying seeking care. Already TB diagnosis is being pushed later and later than it was. Now, on top of it, if we now want a negative COVID test, we are really going to have a hard time detecting TB early. Just to say that this is an important operational issue worth looking at. And is the yield high enough to justify bidirectional screening? I've not seen enough data to answer that question. Shibu, I know you have a question or a comment that you've been waiting to make. Can you unmute yourself?
Yeah, so I mean, the one comment I would want to say that because the situation is still fluid and fluctuating. The UP and Maharashtra situation is, becoming better, as we heard from Vikas also. So we are increasingly seeing new geographies getting second wave or third wave or new wave or whatever it is. So these uncertainties are also affecting the performance of the private sector. So that's something which we need to be conscious. Couple of mitigation measures as from the perspective, the project, the JEEP perspective of engaging private sector, what we have done is that thanks to the Global Fund for quick approval process, that's something which is amazing what we are seeing for offering gene expert from the private sector. Interesting findings that during the COVID days, we got approval from Global Fund for sourcing private sector gene expert using the Global Fund money to reimburse it. And we have seen 10 to 15% increase in microbiological diagnosis in that city. So that's good news. We also got approval for offering X-rays, which is AI-enabled X-rays to source from private sector to offer to them. So we have now two more layers of incentives to the private sector. You get free gene expert and you get free X-rays from the private sector to kind of expedite your diagnosis. So though their clientele has reduced significantly, their tools for accurate diagnosis and improving the quality has improved. We have to wait for some more months to look at how the quality improving, but I'm not optimistic about that notifications is going to improve significantly because we have seen a sequential reduction in our 2 PUDR, to Pro Global Fund from 71% of last PUDR compared to 34% now. because of not because of UP and Maharashtra, which are the major drivers, the other states are driving us down significantly because of subsequent waves coming in. So they were contributing, they were kind of balancing out during the initial challenges, but as the epidemic moved from urban to rural, and all these things are now panning out. I had a couple of suggestions, which is also kind of in line with what Amir suggested. Is we need to invest in private sector right now. We need cushions, tax holidays, or even government of India is supporting industries, the small scale industries. This is an opportunity to subsidize the private sector, because that need to be there. We don't have any other place to go and seek care. So there has to be some sort of a concentrated effort, maybe going as a recommendation or suggestion from this group to the respective governments to consider this. Thank you so much.
What I'm seeing is there are all these large private corporate hospital CEOs that are going and lobbying the government for subsidies or tax write-offs and stuff like that. But I don't know whether it penetrates to the lower primary care GPs or private providers that we care about. We are less interested in the corporate hospitals for TB for obvious reasons. So this is, I think, where the public probably feels very unhappy that the big corporate private hospitals are not coming to the party, not doing enough in this COVID crisis. And there's a lot of anger about the outrageous prices that private hospitals are charging for COVID ventilation and so on and so forth. So public sympathy to giving them benefits is probably not high. And I also think that if they take up all the money, the big corporate hospitals, what does it leave the vast majority of private providers who genuinely need help, the smaller providers and the smaller clinics? I don't know how to answer the question, because invariably the most powerful people who lobbying are Naresh Rehan type of people who will be the top of the pyramid and going and meeting the prime minister or whatever. The average GP is completely missing from all of those picture. So I don't know what the solution is, but I think the public sympathy for any kind of help to private hospitals is very low right now from what I'm seeing or hearing.
You're absolutely right. So there is a couple of, I would say platforms in Indian setting. There are qualified medical practitioners associations, the VAT medical associations in, especially in a city like Mumbai, that represents the middle class of among the private sector, or even lower middle class of the private sector. They can actually act as pressure groups, like leaving aside all these other big, high-end corporate hospitals. One thing is that we still miss the Ayush doctors, and then Ayush doctors. When I say Ayush doctors, they are there, and there might be a switch from the qualified to a unqualified because of affordability issues, and that might really affect the quality of care in long run, because the patient won't get triggered referral to the quality doctors at this time, and they tend to manage it at that level. So there might be issues which we don't know how it's going to pan out right now. Thank you.
Thank you, Shibu. Very insightful. Bola, you had some very nice, insightful comments in the box about bidirectional versus integrated screening. So what exactly is the difference between bidirectional screening and integrated screening, and how do you see it playing out in Nigeria? Go ahead, please.
Okay, thank you, Dr. Pai, thank you, everyone. So what we discovered was that at the beginning of the COVID-19 pandemic in Nigeria, providers were very apprehensive. They didn't want to attend to patients because they couldn't differentiate who they should suspect of having COVID from those who they should take or identify as presumptive TB patients. So what we did was to start by doing clinical meetings online to talk about COVID-19 symptoms and TB symptoms, and to find out the fine differences between the two. For example, one of our most common symptoms for TB, cough of 2 weeks, is peculiar to TB. COVID-19 symptoms would likely have a shorter duration of cough. And then the fever in TB is not so high grade, while in COVID-19, usually high grade fever. And then there will be other involvements of other systems in COVID, like diarrhea, digestive system, loss of taste and sense of smell, and all of that. So we had clinical meetings, and for like 3 weeks, back to back, for different groups of providers, where we reiterated the basic differences so that they could actually differentiate at the triage stage Because if you wait, if you want to make the testing bidirectional, like we said, there were obvious bottlenecks to COVID-19 testing, and that means patients will be stranded along the way. You're going to lose patients, like we have pointed out earlier. But if you start differentiating the patient from the point of screening, so that providers know who to refer and fast track to the COVID-19 testing centers, and who they can comfortably, take TB samples from for testing, then they had more confidence. And we saw the confidence improving along the way. That contributed a lot to our ability to recover, very fast from the COVID-19 disruptions. And to take it further, we had this hub that we developed in Nigeria, the National Coordinator mentioned on Tuesday, the TB Star, on Monday, the TB Star app. So we had to update that app to include COVID-19 screening. Initially, we had just TB screening and then on to presumptive identification and testing and diagnosis and so on. But we now integrated COVID-19. So we have an entire page dedicated to COVID-19. So providers can actually screen for both. And when the patient has one or more signs of TB, it says, oh, this is a presumptive TB patient. But if the patient has COVID-19 symptoms, they have to tell you this patient should be suspected of having COVID-19 and should be tested. So that's what we've been doing in the program.
Thank you, Bola. There's some background noise coming, so if you can all mute your mics, that will be very helpful, please. Thank you. There was a really wonderful comment in the Q&A box. So let's assume that teleconsults are going to become more and more popular in the coming months or years for TV. Is there a checklist for ensuring a quality teleconsultation interaction or episode, right? In other words, can we tell the provider, if you're doing a teleconsult around TB, here are 5 or 6 things you absolutely must do, right? I think we kind of know what they are, basic steps, but is there any quality assurance on teleconsultation services? And Monica, is there a WHO fact sheet or a rapid policy advice specifically on TB teleconsultation service that we would consider of high quality?
Sure. So Madhu, I need to, so we do have in our team, Dennis Falzon, who works on digital innovations. And we do have guidelines in place, and we're looking to develop even more. So we will be happy to share with the team, what is available. And at the same time, the COVID group at WHO is working very specifically on this issue. So we have a lot of resources that we will be happy to share. But indeed, this is the way forward.
So for example, if that quality checklist said short duration cough and fever, consider COVID, 2 weeks cough and fever, consider COVID and TB. Here is the nearest place where sputum can be dropped off, or if you want a home collection of sputum, this is what we could do. How does one operationalize teleconsults? Right now, I think it's a bit of a wild west. People are doing whatever they want and on whatever platform they want. There is no clarity on what is happening, nor am I convinced there's adequate follow-up on a electronic or a digital consultation. Mohammed, you had a nice comment that you made. Would you like to make that on camera, please?
Yeah, thank you very much, Madhu. I just want to highlight the opportunities available as well. The situation is really different and difficult. That's where we need to consider available opportunities as well. And Global Fund, as part of COVID response and mitigating the risk of the COVID on TB, including the disruption, offering flexibilities, to use a grant beyond, the items or the interventions approved, but the flexible way of approaching or reaching people. This includes, rather than waiting for patients, it's more about, following them and going them, and this includes outreach service, engaging communities and private. I think as Shibu has already mentioned, the Global Fund is actually offering, the gene experts and other diagnostic facilities tests to be available in private sector as well. I mean, we are focusing on finding and treating people with TB and ending TB wherever they access service. I think that support should be there. I think the focus is overall, addressing TB in general, whether this service would be provided in private, public, and primary or tertiary at the community. I think that should be the focus, and it is more about synergy and bringing that together. I just keep highlighting that countries should explore opportunities within the Global Fund, but again, beyond Global Fund, and see the opportunities. I just want to highlight that. Thank you.
Thank you, Mohammed. We have Teresa with us now. Teresa, I hope you listened to that important comment that a lot of private providers are doing online consultations now, telehealth. Is there a simple quality assurance checklist that WHO can rapidly develop? Not necessarily a guideline, more a question of like have it clipped onto your your computer screen. Here are things that we must do if we are doing a TB teleconsultation. Is that already being worked on, or could we do it?
So I would probably start once again. Thank you very much, dear colleagues, for this very exciting discussions. I am following carefully, reading the comments. It's really impressive and very useful for me personally. First, I would start probably with from the question: are you following our official webpage with the communications on the TB and COVID? If you are not doing yet, and I mean not only you, Madhu, and also other colleagues, probably you should start doing, because from the very first months of this COVID pandemic, we're starting sharing information how to deal, how to provide services in this very unusual situation. And I would request our colleagues from the team to share this link. And there is regularly updating information note, because it could not be called guidelines. So we don't have enough evidence, but we are not ignoring. And if you will follow, you will find very useful advice and recommendations how to provide TB services in the current situation, including how to use digital tools, about using innovative ways of sharing information. And one is online consulting. It's just the way. If you have information, you can use different ways. And of course, we try to put it very briefly, but if colleagues are thinking that it should be even more brief, we of course can do, but anyway, information is available. Some quick and essential recommendations are there. Please, I will be happy to hear your comments and feedback on them. Over.
Thank you. We are out of time for this panel, and our wonderful guest is with us, Barka Dutt, an award-winning journalist and Washington Post columnist. I'm going to ask Monica to set the stage as well as introduce Barka. Monica, are you there?
Yes, sorry, just putting the spotlight on Barka. Barka, we're really happy to have you join. Thank you so much for taking time out of your busy schedule to be here with us. So I'm Monica Diaz from the World Health Organization, and this year, as I briefed you yesterday, is the working group on public-private mix for TB prevention and care. We have over 100 people joining us. Here today, we had 200 earlier, and we know that many are connected and watching via YouTube and online. And we've been discussing over the past 2 days essentially how we need to strengthen engagement of all care providers, because we are in crisis right now. And we need to have essentially measures in place to ensure that no matter where people access care, whether it's public sector or private sector, they are able to do this. So we're very happy to have you here with us. We've followed your stories very closely on social media, especially. And as Madhu very eloquently said, Barka is, to all of our panelists, Barka is indeed an award-winning journalist. She's got some of the highest awards in India, and she is I've followed her for many, many years myself, and she's a very vibrant speaker, and she goes to the heart of the matter. She has been covering, especially over the past many months, the real stories on the ground, those who are impacted by COVID, by other infectious diseases like TB, the real suffering on the ground. And so we're very pleased to have Barka here with us to give us what we call the big talk, in true TEDx style, perhaps, to kind of give us her journalistic viewpoint, because she's been among those really those who are hurt, those who are affected. To give us your viewpoint, Barka, please share with us on how, what you've seen, and how all of us around the world here who are gathered here, what can we learn from the experiences you've had on the ground in times of crisis? How can we ensure that in our quest to end TB, along with COVID and other diseases, we keep the spotlight on the most vulnerable? So over to you, Barka. Thanks so much.
Thank you, Monica and Madhu, and hi everyone. It's great to be on this very important forum. It's great that one of the things that these strange times allows us to do is to be connected across countries and geographies, and maybe that's the silver lining in this sort of dark moment. I speak here today as a journalist who's been reporting on the ground this year. Pretty much most of the year. I set out in March after India imposed a lockdown, and I spent 120 days on the ground, and I've been returning again and again to the heart of not just the COVID pandemic, but I've spent a lot of time reporting from outside public hospitals, from outside private hospitals, chronicling stories of individual tragedies. And so everything I say is what I have witnessed myself, families I have met myself, doctors, it's all primary data to that extent. I obviously am not a tuberculosis medical expert, but I speak as someone who has seen what has happened to healthcare very much in this year, especially when it comes to being able to access sort of the health system. And what I think, if I had to describe it in one sentence, I would say that the COVID pandemic created a hierarchy among diseases that disturbed me greatly. There are many moral issues that this pandemic has thrown up, especially in a country like India. And I'm sure emerging economies and developing countries all across the world have had to wrestle with this. That essentially, as we locked down in almost blind imitation of what Western countries had done, we basically, to protect the middle and the upper middle class and the wealthy, punished our poorest citizens. And I saw this play out in all sorts of manners, economic deprivation, the economy shutting down. In India's context, the overarching image was that of migrant workers fleeing the cities and going back to their villages. But this also played out in a very, very stark way in terms of healthcare and access to healthcare. And I remember early on in the lockdown, receiving a call from a contact of mine telling me about the story of 4 daughters, literally children, who had cremated their father in a small town in India. And you can see that photograph there on the screen. So what I'm going to do is actually just tell you the story of this one family, to actually tell you the story of what happened to healthcare in India, in particular with tuberculosis, which, as we know, with cancer, is these are the 2 single largest life-claiming diseases in India, and we have that data. And yet, even though COVID was not inducing the same numbers of fatalities as a percentage of population, the healthcare system was obsessed with COVID and actually just forgot all about tuberculosis. So what is the story of this family? This is the story of a man called Sanjay Gupta. Sanjay Gupta lived rather in a town called Aligarh in India's most populous state called Uttar Pradesh. He ran a small tea shop. He basically made ends meet by selling tea. It is a matter of some tragic irony that the Prime Minister of our country is also a tea vendor's son. And I was just struck by the irony of that moment, chronicling the story of this poor tea vendor. These are his children. They're all daughters. This is how they live. You can see the sort of penury in which they live. And these little children had to go and cremate their father after he died from tuberculosis. Now, this was a preventable death. This death took place because essentially when Sanjay called for an ambulance, the ambulances of the cities were not available because it was an overstrained public health system that, as I said, had got completely entrenched in the COVID response. And what had happened was that in the confusion over whether to keep hospitals COVID or non-COVID, a number of public health hospitals, which are usually accessed by the poorest citizens, had become fully COVID. And so even when this family managed to reach the emergency of one hospital, they were turned away from that hospital and then sent to another hospital. And when they reached that second hospital, they were told that this hospital is COVID only. And then they went to a third hospital, and basically by then it was too late and he died. And I profiled this family, and it would be the first of many such families I would meet. And I would keep saying that the three sort of sets of people amongst the poorest Indians that I would meet who were unable to access healthcare at this time were those who suffered from tuberculosis, were cancer patients, and those who had kidney disease. These were the three categories of people that we most often met who were not able to access healthcare. And sometimes this lack of access to healthcare was happening even with middle-class families who had the means to pay for treatment. But think of families who do not have means to pay for treatment, who are being turned away from hospital to hospital. So the stories that got told at the height of the pandemic were the stories of COVID patients and COVID hospitals running short of beds. The stories that never got told was how this was creating a kind of pecking order of infectious diseases. And in this pecking order, COVID was privileged ahead of all other diseases with, in my opinion, not enough data points to tell us that that is how the health system should have responded. And by the way, continues to respond. So even now on the ground, as we are witnessing a second surge in the national capital where I am of COVID cases, every single hospital, graveyard, cremation ground that I have reported from, the feedback is the same. What's happening with the pandemic is happening, but people who run hospitals are saying that they don't actually have the space and the wherewithal to treat those who are suffering from other diseases, life-threatening diseases like tuberculosis. And I think that the gap in our response system continues to be the gap even 6 months on after the pandemic, which is that no one has actually done a stark data comparison over which disease takes more lives and prioritized healthcare response based on how many people are actually in need of help. So yes, I understand that COVID is highly contagious and therefore it has triggered the kind of lockdowns that it has. And I have my own views on the lockdown, which is, maybe time for a separate conversation at another day, another time. But I think that the biggest confusion in the healthcare system has been how to treat those who do not have COVID, who are dying from those diseases. And there has actually been a kind of invisibility of these stories in the media because people are only telling the stories of COVID. And there has been a chaotic gap in the healthcare response. There are two opinions among experts over whether the way to deal with non-COVID poor patients is to have COVID-only hospitals segregated from non-COVID, and different hospitals have dealt with this in India in different ways. Different state governments have dealt with it in different ways. So there are state governments, we do not have a uniform policy on this. We do not have a uniform scientific opinion on this. We do not have a consensus on this. So there are hospitals I've reported on that have turned fully COVID, and outside their gates, I have met any number of tuberculosis patients. Please remember that these are people, when they're poor people, they have already lost their means of livelihood. So I have met tuberculosis patients who are daily wages, who have lost their income in this lockdown. To get to the hospital has often meant a process of taking a loan to pay for some mode of transport or to buy the petrol or the diesel that will go into the motorcycle on which they have come to that hospital. They reach the hospital, the security guard actually tells them, this is now a COVID only hospital, please go somewhere else. They say, where somewhere else? The security guard shrugs his shoulders, says, I don't know, right? So we have, at the best of times, in a functional health system, India's poorest people wait in long line outside our public hospitals. So for example, in Delhi, outside the All India Medical Institute, I met patients who were living in tents on the main road outside India's most famous hospital. These were non-COVID poor patients who just had to wait for days and days and days for a doctor to be able to even meet them because OPDs had shut down, and therefore there was no interface, no normal interface taking place between a doctor and a patient. And it may sound cold of me to say this, but I think the time has come for someone to do the hard math and say that does it make scientific sense? Does it make scientific sense anymore for the health system to be completely prioritized by the pandemic? I am personally not convinced anymore that it does, not because the pandemic is not a very serious thing to grapple with, but because the numbers seem to suggest, at least in my country, that the IFR, the infection fatality rate, is not as high as we had feared. So the prevalence of COVID is very widespread. There are many more Indians who are COVID positive than the official numbers will tell you. The serological service point to that. But the number of people dying from it, even factoring in underreporting, are not as high as our tuberculosis and cancer fatalities. And yet we've actually had no one empirically study this, empirically do the math. And I think that, I was asked, what is the next crisis area? And I said that the next crisis area is going to be twofold as a consequence of this pandemic. One is going to be economic, and the other is going to be the healthcare system collapsing. And it is not collapsing under the weight of COVID. It is collapsing because of its failure to treat non-COVID poor patients. We do not even have the numbers of how many people have died, for example, from TB in these last few months, and how many more that is than the average that die in India every day. So, like I said, I'm speaking here as a journalist, giving you a journalist perspective, but it's really shocking to me that we haven't been able to work out whether the best approach is to have COVID-only hospitals or mixed hospitals, or, not all hospitals are big enough to have wards that are COVID only or sections of the hospital that are COVID only. Poorest patients continue to go to public health hospitals. If I had to end with a prescription, my prescription would be that I would have created, as some cities in India have, jumbo hospital facilities for COVID, and I would have let the hospitals function as they were functioning. I think what we did was we let COVID take over the hospitals. So hospitals that the poor were, used to being able to access were no longer available to them. What we needed to actually do was to segregate the COVID patients. Instead, we blocked the hospitals to the poorest Indians. And I think going forward, we continue to make this mistake. We should have set up COVID-only facilities outside of functional hospitals. And some cities have done it. The city of Bombay, for example, has done it, but most cities in India have not taken this approach. And I think that this is a mistake. So, prescriptively, that would be what I would recommend, in addition to studying the data dispassionately and making a sort of pro and con weightage, not because one human life is more important or less important than the other, but because the health system has to be structured in a way that it responds in the most effective way for all. So I will just leave it there with those thoughts.
Thanks so much, Bharka. That was really, from the heart, and very passionate sharing of what you've seen on the ground, as well as what you think could be potential solutions. You're absolutely right. I think we're all reacting to the situation. We need to have we need to take a step back and analyze the situation, and we need to come up with some hard-hitting solutions. So I'd like to quickly invite our director, Dr. Teresa Kasaeva, who would also like to quickly make a few comments on your intervention.
Yes,
Teresa,
thank you
please.
very much. Barker, you are welcome, and you've mentioned that you are not a TB focusing on TB all the time, but I no doubt that you should become our advocate, strong advocate in future. I was really impressed by your reasonable and very clear points. So I would like to comment on a few of them. First, about information and data available. It is there. We are all trying to highlight and repeat that TB is the biggest infectious disease killer in the world. This information is available in the Global TB Report, annual report. And during this year, we had a special session of the United Nations General Assembly, focusing specifically in the middle of the COVID pandemic on TB. And there was Secretary General progress report with the alerts that TB is badly affected by this COVID pandemic. And remaining the biggest killer, the situation can become even worse. We can see massive outbreaks of TB after this COVID epidemic, and it should not be for us surprise. We should mitigate and avoid this unnecessary further death. So, because based on our modeling already this year, we can predict additional up to 400,000 deaths from TB. It's a huge number, and all lives matter. Absolutely, you're absolutely right. Another thing is about impact on TB services and TB programs. Again, evidence, our close to real-time monitoring shows that it is a fact. This disruption happened. We can see massive sharp drops in the TB notification in the high-burden country. And it means that a transmission will be increased. It's airborne infection. So, and this is another really concerning thing. Another point, I will not go into the details, but we can see the disruption, but we also can see the contribution of the TB programs and services into the COVID response. So TB is old disease, and you can see that new threats are coming and leaving. Their life cycle is much shorter than TB cycle. We are remaining for the decades, for the centuries even. And of course, it's a big concern, but in the same time, it made us integrated with the health systems. And these minor investments were severely underfunded. Even with these investments, we've managed to build network of facilities, network of laboratories. We have excellent health workers and community trained, knowing about infectious diseases, control, about contact tracing. And now the whole systems are benefiting from this knowledge. And it's time to alert. You should invest more in TB, because in the high burden country, these are investments in the health systems. You cannot build urgently every time new virus is coming, some new system, but you can capitalize from the existing so-called old diseases as tuberculosis. And this will be our message. We are thinking not only about patients with TB, but we are thinking about all the existing and potential threats. So, and it will be a request to you as a journalist. We are sharing this information. We are trying to knock all the door of the officials, but being disease of poverty, it's chronically neglected and undermined, and this is our problem. And even with your colleagues journalists, I had experience last time when we are organizing press conference. First question is coming: will you touch COVID? Then we will come. If only TB, we will not be interested in. And again, why it is like this? Of course, COVID is everywhere, but journalists should not neglect TB, and we will need your support. So sorry for being so passionate, but I can't miss this.
No. I like I said, I think this hierarchy of diseases is a very problematic one, and I think COVID has raised all sorts of ethical questions that we're still all grappling with. So I will be glad to put the weight of my journalism behind it. And thank you for having me.
No, and Madhu, would you like to add a few words?
No, first to just say how moving it is to hear these terrible stories from the ground, Barka. And instead of sitting in your offices in Delhi, you were actually in the field, consistently reporting for weeks and months, which takes journalism to a whole new height. So thank you for everything you've done. I just wanted to also echo the point I think Teresa just made. We in public health and global health, for decades we used to the zero-sum game, right? Yeah. That if you spend on TB, then you can't do diabetes. If you do diabetes, then you can't treat drug-resistant TB. At some point, this bullshit has to stop. We have to invest in universal health coverage, end of story. And how is it that countries like India are still only spending 1.5% of the GDP, decade after decade after decade, regardless of which government is in power, which boggles my mind that we cannot seem to understand that health is wealth. This pandemic has demonstrated that if you screw up on health, economy will be torn into pieces and it'll take you decades to recover. So you have to pay up front, invest in health, so that you don't have to pick these brutal choices between COVID and TB. We need both. You and I can get both. You and I can have diabetes and TB and end up with heart disease. Are we going to pick and choose? So how is it that Indian journalists and journalists globally can become champions for just investing in health, just health, all aspects of health?
I couldn't agree more. Totally agree with everything you've said.
Yes, Barka, I mean, so looking at the comments that are coming through, we can see that everyone's saying this is a wake-up call, this is a telling of truth, and it's so wonderful to have this fresh perspective from you. It's inspiring. In fact, even based on what Teresa and Madhu are, I'm thinking maybe we should have a group of journalists from different countries perhaps come together to share these stories, because it's not just happening in India, it's happening in Nigeria, Philippines, Indonesia. I mean, let's just unite forces perhaps to also tell, speak truth to power, in this way. So already there are so many requests to share your clip on social media. I think for us, it's truly been a fresh breath of air, a wake-up call. And I think it's inspiring for us as we plan now the next steps forward in this meeting on how we can strengthen public-private collaboration to reach all people with care. So thank you for providing us with that impetus.
Thank you.
Thank you
for having me, and good luck with everything. Thank you.
Thanks so much.
Bye-bye. Thank you. Bye.
Bye-bye.
Wow, we needed that.
Absolutely. That was, I think, really inspiring, awe-inspiring. So this was Madhu's suggestion. Thank you, Madhu, for proposing. Very often we tend to have the same. We always have our, the same set of speakers, and so it would be good. It's good to have this sort of fresh perspectives. So Madhu, would you like to say a few words in wrap up for your session before we move now to the group work?
Yes, I think we've had a powerful session where we heard the voices of frontline providers. We do realize that we missed rural providers. I think that's a gap in our blind spot in our thinking, Monica, that I think we need to fix in future, maybe have an entire panel of rural healthcare providers in multiple countries, because even for COVID, all the reporting has come out of urban areas. Even in India, we have half the time, we have zero idea how widespread the pandemic is in rural areas. So I take that to heart, and I think this is something we need to actively work on getting better. We just don't have enough insight. And all this teleconsult, as exciting as it is, if most people in rural areas have never heard of it and cannot possibly use it, then I think we need to really rethink what that really means. I think a few things are clear. Private sector is impacted, will need help in recovering, and is adapting. And adaptation is one thing private sector is known for, right? And they don't wait for anyone. They just start doing things, good or bad. They will adapt. They might do some ridiculous things that might fall flat, but they will still try something on the ground. I think learning on which adaptations are working and which adaptations are not working will be most helpful for us. So the TB PPM Learning Network, please be in touch through the Learning Network, join the network, contact Petra, the community manager. If you know of any good adaptation by the private health sector during this crisis that is seemingly working well, we want to know so that we can share that lesson across other areas. Like Mohammed said, Global Fund and others are very open to experimentation. And so if we can learn from each other, that is the purpose of the whole learning network. And secondly, we also want to know what policy changes local or state or regional governments have done to harness private health sector services adequately and make sure things are functioning. As Guy and others have mentioned, countries which already had a viable public-private contract or systems in place may have weathered this storm better than creating a brand new public-private partnership in the midst of a pandemic. You cannot really do in the middle of a pandemic, contract making, moving money from here to there is very challenging. But if you already had a system in place, then activating those is much easier. So the UHC group that you heard on Monday, Dave Clark and others, are mapping innovative PPM models across the world for COVID. And I think we want to know which of them are successfully leveraged for TB and what lessons can we learn from that. And so the policy regulatory environment changes are really critical in my opinion, and what might happen. And lastly, let's help NIM and other modelers in figuring it out better with all the data that we can provide. The most critical question, which is for the next segment, a segue to the next segment, is how do we recover PPM and build it back stronger? What are the most important things we can do right now to recover from the shock and come to at least a level close to end of last year? End of last year were almost like the highest PPM point that I think we had reached. Those of you who came to the Jakarta meeting, we all felt optimistic that things were getting better with PPM, that we were pushing up notifications globally, that quality of care was going up, and now we've fallen off a cliff. How do we recover and come back? And Monica has a nice idea for a breakout session where we can actually work in smaller groups and come back to the plenary with a list of critical suggestions.